Hello, my name is Erica Chapman, and I'm an occupational therapist at Mary Free Bed. I specialize in treating people with brain injuries and post-concussion. I want to thank you for inviting me today to share my passion of post-concussion with all of you. Hopefully you'll find some of this information important to your practice when you get out on your own. So today I'd like to show you a little bit about what is post-concussion, what's the definition of it, some OT treatment approaches for addressing issues that result from post-concussion, and appropriate goals that you can set for your patients that have post-concussion so that they can progress appropriately. So the previous definition for concussion, or the previous terminology, I should say, is post-concussion syndrome. That's no longer the case anymore. The terminology now, the more appropriate terminology is persistent post-concussion symptoms. This is a better terminology mainly because the issues that most patients deal with are a combination of a number of different symptoms rather than a syndrome. And it also paints it in a more positive light that some patients are just they take to a little bit better. So concussion is any kind of trauma that alters the mental status. It doesn't always have to include a loss of consciousness. I believe loss of consciousness can be anywhere up to a couple hours, but nothing more than that. Anything more than a couple hours is usually considered a mild or traumatic brain injury. It can also include loss of memory before, during, or after the event, but not necessarily always. And also any imaging that the patient might follow up with after their concussion. Most imaging should be negative, so if they get any kind of CAT scan or MRI, there shouldn't be any bleeds that show up in that imaging. No damage should be noted. If there is any damage, then of course again it would be a more significant brain injury. So post-concussion and treating post-concussion is kind of a big deal in the US. So mild TBIs or concussions represent about 75% of all TBI cases known, and it's probably likely higher just because a lot of people don't even go in to get assessed for their brain injury if it's real mild. So likelihood of the incidence is probably quite a bit more. It also is significant to note that most of these people that are getting concussions are of working age. So most of these people are employed at the time of the accident, but if you follow up with them a year later, a lot of them are still not working. So that's a significant portion of the population that has not returned to work, and something that occupational therapy can help them with. So what does OT do to help people with concussion? The majority of people that I see that get referred to me are referred to me because of vision issues. Any kind of vision deficit is a pretty big complaint among people who have post-concussion. You can see that 30 to 42% of people after a concussion complain of ocular motor deficits. So that's important to address from an OT standpoint. Another thing that we can provide is that return to work guidelines and goal progression so that we can help those people and improve that statistic of the number of people who've gone back to work following a concussion in a year. So vision assessments are probably the biggest portion of what I do as far as treatment for concussion. Most people that get sent to me are just because of the vision issues. So 3 things really should be checked in a vision assessment with someone who's had a concussion, and that is convergence, saccades, and smooth pursuits. Convergence insufficiency is probably the biggest issue as far as vision goes. A lot of people, you can see up to 64% of people with a mild TBI or a concussion do complain of double vision or convergence insufficiency. You can see on the left side of the screen there, those are some examples of what it might look for your patients who are having difficulty with that convergence. So convergence is Anytime your eyes are not teaming together to focus on an object up close. This is a big problem, especially in modern society, with the amount of time that we have to spend on tasks that are up close. So most people are on a screen, on a computer for most of their day. They have to do a lot of reading. So if you're having this issue with the convergence insufficiency, where you have either that double text or that halo effect, that obviously can make work or any other up close tasks really difficult to do. One way you can assess if they have a convergence insufficiency is by use of a Brock string, which is a really low cost, which is great. And it's something you can issue to the patient also to help them with their home exercise program, so they can progress on their own at home. So the Brock string requires an individual to focus on beads at different distances, and it forces the eyes to team together to focus on those different beads. It usually consists of a long string. It's usually 10 feet, mostly because you need that extra line so that you can tie it off to something. And then there'll be 3 small beads on that string. Usually they're green, yellow, and red. And the beads are spaced out depending on an individual's near point of convergence. For people with post-concussion, for the most part, that green bead will usually be placed at 4 inches, or at least that's the goal for them to eventually be able to converge at that bead at 4 inches. The yellow bead should be at about 10 inches, and then that red bead should be somewhere around 16 inches. So they'll be converging between those 3 beads while they're working with the Brock string. So here's just a nice little video that you can watch that'll help show you kind of how to use the Brock string.
This is the Brock string. We're going to be using this to teach you the feeling of turning your eyes in. The other end can be held by blood. Next, you want to space the bead. Now let's begin. This is how you change the Brock string. First, look at the middle. Now look at the bead. Then look at the right. Keep practicing by looking from the bead. Go from the yellow to the green to the red, and then to the orange. This is what you see. First, look at the middle and clear. Now look at the also notice the middle of the X. In this case, now look at the red bead. While looking at the red bead, notice that there is yellow. Also notice that there is still two middle of the X. Now look at the red bead. It's clear. While looking at the green, you'll notice that there is yellow. You should also notice that two from non-example.
So that's how you can progress that Brock string so that it challenges that patient, because not all of them will be able to have that green bead 4 inches from their nose. They might only be able to converge at 6 inches, 8 inches. So you start at that 8 inches or wherever they're able to tell you they see those strings crossing. And then as they progress, you try to scooch that green bead in closer and closer to their nose. So it's just a nice little brief overview of how to use the Brock string. It's on YouTube, so you can look it up and review it whenever you want to see, the full video. The rest of the video just shows tips and tricks on what to do if you don't see the strings crossing at the right place. A lot of patients, when they have that convergence insufficiency and you're trying to assess them using the Brock string, they'll tell you that they see those 2 strings crossing behind the bead they're looking at. So if they're looking at that yellow bead, they might see 2 yellow beads or a halo of the yellow bead and then that cross behind the yellow bead. They also might complain of seeing a Y shape where they see only 1 string going into the front of the bead and 2 coming out the back. That's usually because the brain is trying to suppress image from the eye that is weaker or is having a harder time turning inward to focus on the bead. So the brain just tries to compensate by just suppressing that information from that eye. So it's also a great way to assess if your patient has a suppression issue of one eye or not. So the video will go on to show you what to do if they do have either of those issues, either the Y or the X in the wrong spot, and how to address it. So it's nice to watch the whole video. Another thing that I like to use frequently is the Dynavision. It's a great way to assess how patients are progressing. You can use it as a kind of a baseline score that you can check their progress. And patients like it too. They get a little competitive with it and they like to see their score improving as their symptoms get less and less bothersome for them. So they do make quite nice progress with the Dynavision. So here's a little video of what the Dynavision does and how I use it. So there are 3 main programs that I use. This first one is called Mode A. Her job is to just hit those lights as fast as she can to turn them off. It runs for 60 seconds, and you want to see how many of those lights they can hit in that 60-second time period. At the end of that, it'll give you a score so you can see how they've done. And then, of course, as they progress, you want to see that number get faster and faster, or more and more hits. We like them to be at 62 hits or more at the end of that 60-second time frame. Let's see here. So this is memory test 1. So I don't know if you can see, but in that little blue screen that's right in front of her, every once in a while a number comes up. It's kind of hard to see from this view because they're such small numbers. So what she's got to do is hit those lights to turn them off and then call out those numbers as she sees them. So this is working on alternating her attention between those lights, hitting those lights and reading off the numbers. So it can be pretty difficult. For this one, we like them to hit at least 50 lights and not have any missed numbers. That's kind of our goal for it. On the laptop that's over on the bottom left, it'll also show you